This video is presented by TRACS WA, Training Centre and Subacute Care. In this scenario, members of the multidisciplinary team are meeting following the assessment of 50-year-old Nick, who previously suffered a pontine hemorrhage. They're reviewing the assessment findings and discussing management considerations for his continued tracheostomy weaning.
So I thought that was a really good session with Nick today. We got some useful information, and maybe now would be a good opportunity to just have a catch up and look at where to next with managing his tracheostomy.
Yes, I thought it went quite well. What's your opinion about today's assessment?
Yeah, I agree with the both of you. Nick did amazingly well compared to what he was doing with us. He did very, very well. And he also did bring to our consciousness that there were other things he could do in the sense of moving on to the next step. I think he's already there.
Oh, good. Are you talking about the vocalizing?
I'm talking about the general and the coughing process.
Yep.
I think, Nick, you have to advise me on what next to do with him. Do we go with downsizing the tracheostomy tube? Do we go with the fenestrated one of going coughless? From the observation concerning the assessment we did earlier, I think he's prepared to move on to the next stage.
So I think, certainly your thoughts in terms of his secretions and things today, Mana?
Yeah, from a physio point of view and going through the tick list, what I observed today was that he has an efficient cough. He seems to have good insight into his own secretion management. He can ask if he needs suctioning or not. He didn't sound wheezy or any issues with airway patency or stridor. His sats were maintained fine, above 95, both times when he was occluded and not occluded.
Yeah, I think given his history of stenosis, for me it was really interesting to see that he actually did quite well when Tanya was occluding his trachea today. He wasn't struggling for breath, and he also was able to get some really good voice, so that's very encouraging. I think maybe swallowing wise there's obviously some difficulties that he's still having, but the fact that he hasn't had any aspiration related chest infections to date, and that he's not needing copious amounts of suctioning of saliva from his tracheostomy, they're all good things in terms of moving forward with his decuffing. And so now really it's about figuring out what usually happens within Brightwater and how you usually manage these patients, and whether there are any things that we might do differently or that we can put our heads together and figure out a suitable plan forward.
Usually with the coughing here, what we do is we try to make it as unique as possible because every of our client differs.
Yeah.
So with Nick, the next step for us will be looking at downsizing the cannula to a size 4 Charlie, and also, who knows, putting it in the fenestrated tube. But what are your thoughts? What
you're asking is whether there may be some benefit in changing his tube to a smaller tube or a fenestrated tube, or is that what you had in mind, or a cuffless tube even?
Yes.
So at the moment Nick has a size 6 Shiley's in place. So I guess if we're thinking of the kind of neurological trachea population that we tend to work with most, often what we do is once somebody's tolerating a reasonable amount of cuff deflation, we would perhaps proceed to 24 hours of cuff deflation. And then we would look at whether they can tolerate occlusion of their trachea, either with a finger or with a speaking valve. And often for those patients, we can get them to the point of decannulation from there without having to go down the path of changing trachea tubes. And I wonder whether with a patient with Nick's history of difficult tube changes, whether that may reduce some of the trauma or discomfort for him, as if we are able to avoid those tube changes. I mean, I can understand certainly where you're coming from, and that it's easier for, or it would be easier for Nick to have a cuffless tube in situ or a smaller tube in situ. We just have to, I guess, remember, you know, he's a good-sized man, and so putting a smaller tube in may not actually fit him properly. And in terms of the fenestration option, there's always the risk of granulation with the tissue in the throat, or trauma to the airway when suctioning might be done incorrectly, say with the fenestrated inner cannula in situ instead of the non-fenestrated inner cannula. So there's all of those risks that we want to manage and ideally avoid for a patient like Nick. But what are your thoughts on
that? Sounds
on
good
that?
to me. I think we first off we have to try and see if we can increase the hours.
Yeah, and I think
see how he goes with it. Yeah, that sounds very good to me.
And
I
how
agree with you.
would we go just in terms of his, I know Nick loves his community outings, and obviously for safety reasons it's difficult for that cuff to remain down while he's off-site having his community access visits. So have you got any ideas about how we could manage that?
Yeah, what we would look at doing is while he's out there in the community, we would not be decuffing him at all. Then when he comes back to us, we would look at maybe extending the hours more at night, or we start early, say 3 a.m. and finishes up at about 9 if he's up for 6 hours of decuffing or more. But definitely we would not be decuffing him while he's out there in the community. Another thing we might look at doing is if he gets to the stage where the hours are now too much that we can't manage him here, we might send him off to you guys.
Yeah, would it be a possibility to compromise with Nick just for a short period of time, instead of going on his outings, to remain at the facility and just do a consecutive amount of time during the day?
Yes, that's another option. We might have to cancel all of his community outings.
Just an idea, yeah.
Just for the period of time for which the coughing lasts. Yeah.
It's usually, and again, it's different in an acute care setting, but we would be aiming for, say, maybe 24 hours of continuous decuffing. And so even if Nick was able to manage a day or 2 days, perhaps with the cuff down for the full time, he may not get his community visits, but if he knows that at the end of that there's a potential goal of getting the tracheostomy out, then hopefully he'd be motivated to give that a try.
Yeah. Another challenge for us is that we've got one nurse on site.
Okay.
Yeah. We've got 2 houses or 2 units here, so we've got one nurse for one nurse looking after each unit. So that will be a very big challenge for her to get to do that for the extended hours, and also have to manage our other clients. So we wouldn't want to be doing it 24 hours on site.
Okay, so perhaps looking at a hospital transfer before right before he's at that point, so that nursing supervision could be provided in a more supported environment where there are those staff on hand at all times. The other thing that I think would really need to take place before Nick would be able to have his trachea removed, we know that he's got some kind of stenosis, he's had these difficult trachea changes, so really our protocol would also be to have ENT involved to come and just scope his airway to make sure that there aren't any major obstructions or physiological issues there that would lead to yet another failed decannulation attempt, which is the last thing that we want for Nick at this point.
What we would do from our end is tomorrow we'll be having a team meeting where we would have to put all these options on the table, and obviously we'll be taking your recommendation on board. After that, we would also have to talk through it all with Nick, and also set goals on moving forward, and have a chat with his family as well to see if they are happy.
The next steps potentially for managing Nick's trachea would be looking at extending and maximising how much cuff deflation he can safely have in this setting before you would need to transfer him to to a hospital, but also maybe looking at trialling some periods with the speaking valve so that he can build up his tolerance to that occlusion as well to prepare him for decannulation down the track. In terms of other things that we might need to consider prior to decannulation, having that ENT review just to look at his upper airway and airway patency would really be essential before we could move forward with decannulation. And then
get some spirometry involved while he's in hospital, just to get an idea of lung volumes.
And down the track, even swallow-wise, we could look at doing a video fluoroscopy or a fees assessment to get a bit more information about what direction to take with his swallow rehab as well. How does that all sound?
Fantastic. They sound very good, and all the recommendations are very interesting to me. They sound very interesting to me, and they are things we would like to take on board. I would definitely be going back to meet with other members of the team to put all this before them, and we would be meeting with Nick as well to set up goals.
Okay, great.
And we would definitely be getting his family involved so that we're all on the same page.
Okay.
Yep. And I can also talk to Jeremiah about some work of breathing exercises, and if you guys have a tilt table here, doing that combined with the decuffing and speaking valve is something that Eva and I have certainly tried in the acute setting very successfully, just for the diaphragmatic breathing control. Yeah. So.
Okay,
That sounds
great.
interesting. Yeah.
All right, lovely. Well, hopefully that's been of help.
Yeah, thank you for having us.
Thank you so much.
Yeah.
Following decannulation in March 2017, Nick's stoma is healing and he's undertaking regular chest physio, swallowing and breathing exercises with his multidisciplinary team. Nick's goals are to be able to use his voice and speech functionally and to experience some tastes for pleasure. He also now has the freedom to access the community more frequently and is motivated to continue with his rehabilitation. Nick's world has opened up. TRACS WA would like to thank the staff and management of Brightwater Care Group for their involvement in this project. This project received funding from the Australian Government.